Thank you very much for this kind introduction. Ladies and gentlemen, dear colleagues, first of all, I would like to express thanks to the organizers for the kind invitation. Most commonly, right heart dysfunction occurs in the setting of severe left heart disease, increased afterload, such as pulmonary hypertension or congenital heart disease. However, I will take you to the other side of the spectrum, which is that of the endurance athletes, in whom cardiac outputs and pressures go up into the normal range, but during exercise. So to enable this substantial cardiac output augmentation that occurs during exercise and the supranormal workloads, there are several functional, electrical, and morphological adaptations which are well known as the athlete's heart. Here you can see an example, and on the right you see a non-athlete, and I've just adjusted the size of the image so that the scale is the same. And you see that the endurance athlete's heart is almost twice as large as that of the non-athlete. And of course, these are very useful to augment cardiac output, but these changes also make it more difficult to distinguish between physiology and pathology, particularly when there are symptoms around. And I'll illustrate this clinical conundrum in a case of a female rower who was seen as part of pre-participation screening. Her medical file is completely benign, so no family history, and she's completely asymptomatic. Let's have a look at her ECG. And the most striking abnormality here, the most striking change, is that there is T-wave inversion in the right precordial leads, which could be associated with an underlying arrhythmogenic cardiomyopathy. So an echo was performed. And also here you can see that the right ventricle is a bit dilated. There is substantial trabeculation, and not so well seen on this image, but there's some slight impression of hypokinesia at the apex. So really the question pops up whether this athlete has an underlying cardiomyopathy or whether it's just athlete's heart. And this is not just not such an uncommon scenario, because if you look at a large proportion of Australian athletes, more than 1,000 cases, we see that in the elite endurance athletes, T-wave inversion in the right precordial leads occurs in up to 14% of the athletes, creating quite substantial overlap. And this is much more prevalent than, for example, in non-endurance athletes and non-athletes. And the distinction is very important because we know that, especially amongst young competitive athletes, an underlying cardiomyopathy is the main cause of sudden cardiac death. Now, fortunately, we have to put risks into perspective. We know that sudden cardiac death in young athletes is a rare event, and in most cases, it is by triggering ventricular arrhythmias because of the trigger of exercise. However, the question has been raised in the previous decade whether exercise by itself, particularly high intensity endurance exercise, may promote or induce an arrhythmogenic substrate. And this has first come up with this report by a group of Hein Heidbuchel from Leuven, who reported on 46 elite athletes presenting with complex ventricular arrhythmias. Very interestingly is that they found that up to 19% of the arrhythmias originated from the right ventricle, which was quite unexpected at the time. These were not benign arrhythmias because 9 of them had a sudden cardiac arrest. And also intriguing was that a family history is only positive in one of the athletes, suggesting that this is not just an underlying genetic disorder, but that other factors may have played a role. And in this case, particularly the suspicion was towards endurance exercise. More evidence to support this premise comes from the group of Barcelona. They created these marathon rats by training rats on a treadmill for 16 weeks, calculated that it was equal to about 10 years of marathon training. And they did histology, echocardiography, EP studies, and found that myocardial fibrosis after the 16 weeks of endurance exercise was present in both atria as well as the right ventricle, but not in the left ventricle, and that ventricular arrhythmias could be induced far more commonly in the marathon rats. Do we have evidence of myocardial fibrosis in human athletes? Well, this is a study by Melbourne group, by André Lagerge, looking at 40 well-trained endurance athletes participating in a range of endurance events. And it was noted that out of the most experienced, well-trained athletes, 5 of them had evidence of delayed gadolinium enhancement, most commonly at the hinge points, as well as the interventricular septum, which resembles a little bit the spots that we also see delayed gadolinium in patients with pulmonary hypertension. I'll come back to that. So perhaps if you want to understand the link between endurance exercise and RV problems, we should look at the heart at the end of an endurance race event. This is what André did in his study. He evaluated 40 athletes before and after a range of endurance events by echo, and he saw quite a different response for both ventricles. So if you look at the image as well as the figure, you see that left ventricle after the endurance exercise kind of fell off the image here, but it was not really affected. If at all, it became a bit smaller. But the right ventricle was completely different, and the right ventricle enlarged, and you can see that really function was severely diminished after the endurance race event. This is maybe easier to visualize. If you look at ejection fraction, we see that there was a significant drop immediately after the race, and this was more profound in the athletes that participated in the longest race events, which was the complete Ironman. Good side of the story is that 1 week later, all of these abnormalities kind of renormalized. Now, some might argue that these changes in RV function after the endurance race event may be because these images were obtained in the rested state, and that may be differences in loading conditions and autonomic influences that occur after exercise. So we wanted to look at the heart during endurance exercise. Now, to enable to do this, we need a good imaging technique, and therefore in our center together, this has been a collaboration with radiologists, cardiologists. We developed a tool based on magnetic resonance imaging in which we could evaluate biventricular volumes during strenuous exercise and during free breathing whilst exercising in the CMR bore. And we were able to obtain images up to heart rates of 180 beats per minute. So is this a valid imaging technique? Well, in a feasibility and pilot study, we asked 17 subjects to undergo radial pulmonary artery catheterization, and we compared CMR measures of cardiac output versus the gold standard of FIC and found very good correlation as well as agreement between both techniques. So we have a good technique to assess the heart during exercise. So if we switch back to the endurance event, we asked 14 male athletes to undergo exercise CMR at baseline a few weeks before, and then at the end of an endurance race. And to really get images immediately during exercise at the finish line, we asked them to continue cycling up to the hospital, which was up the hill. In the hospital, we had a series of ergometers lined up such that they really cycled until immediately before the MRI. And actually, we found quite the same response. So green lines indicating ejection fraction from rest to peak exercise before the race, and red you see at the end of the race. For the left ventricle, not much difference. Contractile reserve was similar. But if you look at the changes in RV ejection fraction, at rest, not so much different, but during exercise, really reserve, or functional reserve was better before than at the end of the endurance race. Very similar experience, but sometimes the question pops up, is it now more intensity of the race or is it more the duration that is important? And so this was very elegantly evaluated by the group of Queensland. They had 10 recreational exercises that performed both a 90-minute intensive exercise and then 120 minutes of moderate intensity exercise. And so they were able to calculate that total mechanical load was the same in both conditions. And then they performed exercise echo both throughout the exercise duration as well as up to 24 hours after the exercise bout. And you see here left ventricular reserve, this is for strain, where a more negative value indicates better contractile reserve. And you see that only with the intensive exercise regimen, there was a slight reduction in LV augmentation. But for the RV, you see that the changes are much more profound. So RV augmentation actually really completely reverses at the end of the endurance exercise, and this is up to 24 hours later. And you see that also the effect of intensity is much more important than the duration of the event. So why is it now the RV that is most important in the endurance athletes? And we believe that this has to do with the hemodynamics that occur during exercise. We know that relatively PA pressures go up much more profoundly than systemic pressures, and therefore, whereas wall stress at rest for the systemic ventricle is lower during exercise, for the right ventricle wall stress increases disproportionately. And so, whilst the majority of athletes develop balanced remodeling of all cardiac chambers, there may be some athletes in the long term, perhaps due to intensive regimens or insufficient recovery, may go into this vicious circle ending with scarring and arrhythmias. Now, some people were still not convinced, and they argued that this would be an underlying genetic disorder. So, in a follow-up study, Andre looked at the prevalence of underlying desmosomal mutations and basically found that the number of subjects with ventricular arrhythmias who had a mutation was much lower than previously reported in the literature. And this experience was also mirrored by data by the US of Hugh Calkins. They looked at their total ARVC database, and they divided these subjects up into those in blue, which are called gene elusive, so indicating no desmosomal mutation, in green desmosomal mutation, and then split them up into no family history or family history. And as you can see here, interestingly, those with gene elusive and no family history were much more inclined to be engaged in endurance sports than the other groups. So again, a signal that the endurance exercise itself may have to do with the progression of the disease. Important for clinicians is how do we now pick the athlete at risk of this phenotype. And in the original study by Heidbuchel, it was found that during EP studying, the inducibility of re-entrant ventricular arrhythmias was the strongest predictor of outcome. But of course, EP studies are quite an invasive strategy, and especially given the number of athletes with symptoms and with T-wave inversion, we cannot do this in every athlete. So we wanted to have a more non-invasive imaging technique. So we used our setup using the exercise CMR. For this purpose, we used invasive pressure measurement to really look at the RV during exercise. We had three groups. In green, a group of healthy endurance athletes, in blue, non-athletes, and in red, endurance athletes with ventricular arrhythmias. All had pulmonary artery catheter and underwent exercise CMR. And as you can see here from the graph on the left, it's pulmonary artery pressure plotted versus cardiac output. We see it's not a problem of afterload because PA pressures went up to the same extent in the three groups. But the problem is really in the ventricle because RV ejection fraction increased substantially in the healthy subjects, whereas in the athletes with arrhythmias really have a reduced functional reserve of the RV. Here's just an example. At rest, you see that ejection fraction is in the same ballpark. But during exercise, significant increase in ejection fraction for the healthy athletes, whereas in the athlete with arrhythmias, there is no change in ejection fraction. Just to confirm that diagnostic accuracy was much better during exercise. Can we do the same with echo? The short answer is yes. We used several parameters of RV systolic function and basically shown the same graphs as for the exercise CMR. Recently, we've done the same using deformation imaging, strain and strain rate during exercise, and actually found that strain rate was probably the most robust parameter to distinguish between the three groups. I'll just skip this for the sake of time. Recently, the group from Utrecht, they also looked at a register or at all their patients who underwent scar-related ventricular tachycardia ablation and split these cohort up into those with scarring at the subtricuspid region versus those with scar of the right ventricular outflow tract. And actually they found that particularly this phenotype, all of the subjects with isolated epicardial scar in the RVOT were very highly engaged in endurance athletes. And so this may show you that also endocardial mapping, combination of imaging as well as invasive EV testing in a subset of athletes may really be important, because epicardial ablation in these subjects actually proved to be curative. Now, it should also be mentioned that all of these athletes with epicardial scar also stopped endurance exercising. And this is just the final study, just highlighting the importance for the management, because again, the group of Baltimore have shown that out of ICD-treated patients with ARVC, those who stopped endurance exercise actually had the best outcome with less treatment for the arrhythmias. And this was particularly in the subjects without any underlying mutation. So to wrap it up, we know that from both ventricles, the RV undergoes disproportionate work during exercise, which may in some cases lead up to maladaptive RV remodeling. Diagnosis of this phenotype is quite challenging because of the extreme adaptation in endurance athletes, as well as abnormalities being only rather mild in athletes with ARVC or with RV problems. And exercise evaluation may prove useful in these cases. Risk stratification is extensive and involves different examinations. An important clinical message is that competitive sport, particularly high-intensive endurance sport, is contraindicated in athletes with underlying RV disease. I would like to thank all of the people contributing to our projects.
Very good.